Well, good afternoon, everyone, or good morning, depending on where you might be calling in from. And speaking of which, please take a moment, if you wouldn't mind, to type into the chat where your most recent vacation may have been, or perhaps where you plan to head to next. Let's see hopefully some exciting answers here. Blue Ridge Parkway, that sounds so fun. It's got to be beautiful too as we move into the fall. That's exciting. Oh, November, Puerto Vallarta. I like it. Westport Beach Camping. Wow. Let's see what else. Eastern Caribbean. That sounds fun. And for those that are just joining, we have our folks that are on the phone telling us either where they've been recently for vacation or where do you plan to head to next. So we've got some exciting responses coming through in the chat. Walt Disney World this fall, Alaska next May. Wow. September, Iowa City for the Iowa versus Iowa State football game. Wonderful. That sounds like a lot of fun. India, very exciting. Germany, oh my goodness, look at this. Panama City Beach. These are exciting. Dominican Republic. Rob, we may have to join some of these folks. This sounds way too fun than perhaps sometimes what we might be doing day to day.
Agreed.
Look at this, Dominican Republic for a 25-year vow renewal. Look at that. That is beautiful. Oh, very exciting. Tampa. These are some great locations. Very nice. Well, good. We'll go ahead and get started here. Thank you everyone for joining us for this topic of the new formula for higher HEDIS performance. We are certainly glad you're here today. And today, we're really going to talk about something that on the surface, it looks like a change to HEDIS in the STARS rule book, but really underneath it represents, I would say, a much bigger shift in how we think about quality. And the question that I want us to explore over the next 45 minutes or so together is, are we still designing our quality strategies around closing gaps, or are we actually designing them around changing outcomes for members? And I'd love for you to get involved right from the start. So let's go ahead and get started here. We'll walk through some of this. We'll walk through some housekeeping items, and we'll save Q&A for the end. So as we look at some of the housekeeping before we begin, you will be muted during the session, but we want this to be interactive. So there might be some prompts. Please type them into the chat as you hear them from Dr. Rob or myself. You can use that Q&A box at the bottom of your screen throughout the presentation, so not just at the end. We're also going to be recording today's session, so you'll be able to revisit the conversation and share it with colleagues. And please don't wait for the formal Q&A. If a question comes up, like I said, just drop it in as we go, and we will try to incorporate as many as we can as we're moving through. So let me do a quick poll here. How many of you have already started planning for the calendar year 2027 STARS changes? And you can just type it into the message there. Very good. I've got thumbs up. Yep, I've got yes, perfect, wonderful. That's very exciting. And as we take a look at that, this is where we'll talk about not just kind of background, but really why this conversation is just so critical. So a little bit about really our session, and you'll notice how our materials now say powered by Fuse Health. And what that means for you is that Let's Get Checked is now part of a larger, more integrated healthcare ecosystem. It's more than just a branding change. It really is an ecosystem that brings together specialized capabilities across diagnostics, engagement, pharmacy, and care delivery. What stays the same, though, is our commitment to making healthcare easier for members. and easier for organizations, I would say, to operationalize. So what changes is the actual toolkit that we can bring to the table. And ultimately, Fuse Health is about connecting people. It's connecting people to the right care at the right time in ways that we can improve quality outcomes and value. So that's just a little bit about Fuse Health here. So, how are we going to spend the next 45 minutes? We'll walk you through four main concepts here. First, what's changed in the calendar year 2027 final rule? And more importantly, what those changes mean for the math behind stars. Second, why preventive care can be much more than just a gap closure exercise. It can really be the front door to whole person care. Third, why timing matters. So much of what you're trying to do to improve clinical outcomes really relies on the timing, and that matters. And finally, we'll talk about something that I think is increasingly important. It is choosing a partner rather than adding just another point solution. As I mentioned, we'll leave time for questions at the end. So if you had to pick one right now, this is where we need your engagement. If you had to pick one right now, what is your biggest challenge? Is it measure changes? Is it member engagement? Is it timing? Is it vendor complexity? So if you had to pick one of the, and maybe there's something else, but if you had to pick one of your biggest challenges, measure changes, member engagement, timing, or vendor complexity. Let's see what folks are saying here. I see member engagement. Absolutely. I think many of us on the phone can agree with that. Member engagement, 100%. Yep, engagement. Provider groups, partnerships. Okay. Collaborating data exchange with vendors and providers. Absolutely. That can be quite challenging on many occasions. Very good. I can certainly agree with some of those, as I'm sure you could as well, Dr. Rob. So let's get into some of our background. So my name is Bina Thomas. I lead strategic partnerships for Fuse Health. Much of my career has really been focused on population health, payer strategy, finding practical ways to improve engagement and outcomes at scale. I'm joined here by Dr. Robert Morgan, a certified physician by the American Board of Urology and leads a robotic surgery program. He believes in using proactive and preventive care to give people direct access to the tools and knowledge that they need to understand their journey. I always love really providing these webinars and walking through some of the content with Dr. Rob. So it's an honor to sit alongside you, Dr. Rob, and I hope we'll be having some fun here over the next 45 minutes.
Thanks, Bina. I feel the same about you. Appreciate it.
Wonderful. Let's keep moving through the equation. Really, when we take a look at the equation has changed, that's the headline here today. But what does that really mean? 11 measures are being removed, largely concentrated in operational categories. And while depression screening is entering the STARS game for the first time, diabetes care, eye exam, which has been proposed for removal, was actually retained. So I think the bigger takeaway is not simply the number of measures going away, it's where the emphasis is moving. We're seeing greater weight placed on outcomes, experience, access, and less reliance on measures that are primarily there to demonstrate operational performance. So for us, the question becomes, can a health plan strategy or can your strategy demonstrate that care happened, that the member's health actually changed, and that member experienced the system in a positive way? So, as we take a look at that, let's kind of move into what I call the loss of the cushion. And really, what does that mean when we say the cushion is gone? For years, plans could lean on areas where they had strong operational control. Appeals were handled on time, call centers performed well, complaints were resolved. And though those capabilities still matter, the relative weight is changing. The future score increasingly depends on three things. Did that care actually happen? Did the clinical result actually change? And lastly, here you'll see, and how did the member experience that care? Now, that is a very different operating challenge. You can optimize a process in a matter of weeks. You cannot manufacture a clinical outcome at the end of the measurement year. So I'd love to sort of hear again from folks around the table and some of the payer leaders that I see here that have joined us today, which of those three, care, outcomes, or experience, is hardest for your organization to consistently move? So again, for the audience, which of these three would you say care, outcomes, or experience is the hardest for your organization to consistently move? Outcomes, outcomes. I like what someone has said here. You can build the best program, doesn't mean members are going to participate. I couldn't agree more. Absolutely. I see care and outcomes, outcomes, overwhelming response around outcomes and then results. Absolutely. Agreed. And the urgency becomes even clearer when we look at where preventive care stands today. So as we move into this next slide, let's put the problem in perspective. Only 5.3% of US adults 35 and older received all of the high priority preventive services recommended to them. And more importantly, that number is actually declining from 8.5% 5 years earlier. So this isn't a STARS problem. This isn't simply a STARS issue. It's a population health problem. We have millions of people who are technically eligible for preventive care, but they aren't completing it. And then that forces us to ask a very different question. What is preventing people from getting the care that we already know can help them? So let's take a look at this. And Rob, we know this is the response here, the answer here is much more nuanced than simply saying members don't want care. Would you agree?
100%, no question, Vina. It's really not an issue around, if you look at that large swath of the population, somewhere in the 95% range that really are not completing the necessary screening tests on a regular basis. Uh, for a lot of them, it really is not because they didn't know about it. Um, they may not know in the granular detail about what the screening might need to be, but generally speaking, I think people know, like, hey, I really ought to probably go see my doctor, or it's probably time to get some tests done. And so if you begin to drill into what's driving that 95% and made that number go in the wrong direction over the years in terms of, are enough people getting tested? About a third of those patients roughly will respond that it's simply because of a cost issue. It's about 38% at the last measure. Now, if you talk about a 38% number in terms of cost, this is a little scary because this is the highest it's been in the last 2 decades. And I would proffer that that number is only going to get worse. If you look at financial pressures that are happening throughout the economy and certainly in the healthcare ecosystem, um, increasing pressures on Medicare and Medicaid spending and funding, that number is likely to get even worse. But that still doesn't tell the whole story. So while the cost number is real, it's not the entire story. Probably somewhere between 20 and 25% have delayed or avoided testing that has nothing to do with financial considerations, or at least not in terms of the direct cost of getting the testing done. For these individuals, it's sort of the activities of daily life and the realities of daily life that intervene. So, they're too busy to get the testing done. It's inconvenient. It's hard to make an appointment. Maybe geography plays a role, particularly if you think of our rural populations. Rural healthcare has been for a number of years and continues to be in crisis. Access is shrinking, particularly in the rural healthcare markets. And so, the ability for somebody to physically get to an area or a place or a provider to get the proper testing done may be a challenge. perhaps it's hard, if not impossible, for them to find a provider that takes their type of healthcare coverage. And particularly, think of some at-risk populations, Medicare and Medicaid populations. This can be a real challenge. Um, so for a lot of these patients, it's not that they didn't know they needed to get some testing done or some specific testing done. It's all of these other barriers that begin to pile on top of each other. But eventually, at the end of the day, that still leads to only about 5 or 6% of the population that should be getting tested actually getting tested. Now, why does all of that matter? Well, I think if you want to put it in sort of stark clinical terms, it's the if you delay testing and therefore delay potential diagnosis, that has a tremendous impact on clinical outcome. And the delay and impact on clinical outcome can be pinned back to real significant financial impact as well. What do I mean by that? So if you look at the scenario of colon cancer screening, we're going to talk a lot about or mention colon cancer screening a lot as one of the measures. Um, if you have an individual who undergoes screening, is detected to have early stage colon cancer, which if you're doing your screening on the regular basis and per the recommended guidelines, if you're going to get colon cancer, you should then therefore be detecting it in its very early stages. If it's found in its very early stages, highly treatable and highly survivable. Well, what does that mean in terms of real dollars? Well, what it means in terms of real dollars is less expensive to treat when it's caught early, and you then return somebody or maintain them in very good health so they stay active members of their community, they're actively employed, they're paying taxes back into the system. All of that becomes important. If you then flip that to patients that are found with disease that is very late at the time of the diagnosis. In other words, their disease is discovered not because of some testing that's done, but rather waiting until they've got symptoms from that disease. By the time they've got symptoms, very often the horse is out of the barn, the train has left the station, the disease has spread. The cost impact to treat that goes up dramatically. And at the same time, obviously, the survivability of that disease decreases significantly as well. And so, in terms of real financial impact, we're spending trillions and trillions and trillions of dollars, 5.3 trillion currently, on managing chronic health conditions, mental health conditions. And this is only going to increase in the years ahead. So there are real dollars tied to this. And honestly, besides the ethical reasons to keep the population healthy, it's really why a lot of these screening methodologies and dollars tied to them in terms of HEDIS and star ratings have even evolved. It's because, well, ethically, we want to keep the population healthy. There is a significant financial upside to doing that also. And so they go hand in hand.
Absolutely, Robin. And for me, this is where the clinical stakes become very real. It's what's happening inside the member that we don't know yet. It hasn't been found yet. That's the
Yeah.
clinical question. It isn't a marketing question. It's a
No,
clinical
exactly.
question.
Yeah, exactly. I think and look, for many individuals, it's very easy. I'm guilty as charged. I mean, it's very easy to put our head in the sand and sort of, well, I feel fine. There must not be anything going on. I'll get that testing done next week or next year or what have you. But the reality is that just because you haven't made the diagnosis doesn't mean clinically that the disease doesn't exist. So again, if you look at sort of these top targets in terms of diseases that we try to screen for when we run screening programs around gap closures, colorectal screening. Only about 1 out of 3 people that should be getting tested are actually getting tested. And this, relates to non-invasive testing um, uh, uh, measures. But as we're going to talk about and how the goalpost is now moving in 2027 and beyond, it's not even going to be enough anymore to say, well, you got tested, but it's then you've now got to take that next step and say for the abnormal, the patients that have an abnormal result, then going and getting the next level of testing and or intervention that's really going to matter and really going to close the gap. So, you use the term early in your presentation around point solution. That's why we've got to be thinking around, I think of it as circle of care or longitudinal care. It's not enough to just say, well, we did the test, we're done. That might have been good before and as a starting point, but it really, in terms of trying to improve outcomes and certainly trying to just, close gaps in care, it's not enough. Um, Diabetes, pre-diabetes. I think probably everybody on this call at least appreciates at some level the tremendous burden that diabetes places in terms of an individual's health. I mean, diabetes and a patient who has diabetes, it streams into a wide host of other disease states, increasing risk of cardiovascular disease, increasing risk of renal disease, higher infection rates, et cetera, et cetera. What's interesting about diabetes though, is that except for a certain type of diabetes, most patients that become diabetic e- evolve to diabetes. In other words, they're in what would be considered a pre-diabetic state at some phase and then move into a true diabetic diagnosis. If we can screen people and detect them in that pre-diabetic phase, you can be quite successful in intervening in that with that individual through a variety of options, including diabetes or dietary and nutritional alterations and education, uh, uh, importance of activity and exercise, implementing some of those kind of programs, and even medications. So you can actually take somebody that's a pre-diabetic who, for all the reasons, would have been on the course to evolving into diabetes and actually make sure that that never happens. And yet, with that sort of very effective treatment and diagnosis and treatment modality available today, still 8 in 10 people who are pre-diabetic don't even know it. That's over 100 million people in this country alone. And then the last one we'll talk about briefly is chronic kidney disease. Kidney disease is very, very silent until it isn't. And I mentioned earlier, often with some of these different clinical conditions that we talk about, you'll never know you've got the issue until, again, horse is out of the barn, train has left the station. Kidney disease is one of those. You could be well on your way to renal failure, but you're never going to know it if you don't get tested until unfortunately you've got renal failure. And by the time you've got renal failure, that train has definitely left the station. And so now you're talking about patients being assigned to have to be on dialysis. Very cumbersome for the patient, very impactful in quality of life, very expensive to the system. And so again, if we can diagnose a patient very early on that journey, well before they get to that end stage of renal failure. Lots of interventions that can be done to steer the ship off the rocks miles and miles before it ever hits the coastline. And so that's why these are really important. But you look at those numbers, pretty shocking in terms of who should be getting tested versus who actually is getting tested.
Yeah. And really, an undiagnosed condition doesn't mean it's an absent condition. It just means it's an unknown condition, really.
Yeah,
And
asymptomatic at that point, correct.
absolutely. Well, thank you, Dr. Rob. That is the clinical case for urgency. Let's kind of move into the three shifts and how to respond to it. When we talk about these three shifts, we believe there are these three very practical ways or things that plans can do and shifts that plans can make. One, front door. It gives members more than one way into preventive care. Two, we call it the calendar. Stop treating quality improvement as a fourth quarter event and create enough runway for clinical intervention and remeasurement. And then third, the partner, move from, I would say, a collection of disconnected point solutions towards a partner that can help orchestrate the full member journey. Now, none of these require abandoning everything you're doing today. What it requires is just redesigning how the pieces can work together. So let me ask the audience here that's joined us. We've got quite a number of you on the webinar that's joined us. Very exciting to see. But if you had to fix just one today, which would be the biggest, which would have the biggest impact for your organization? Front door, giving members more than one way into preventive care. Calendar, stop treating it as a fourth quarter event. Or partner, move from what I was talking about, a collection of point solutions, towards one that could really help the full member journey. Let's see what's coming through on our chat here. I see calendar. Very good. Calendar and partner in parallel. That's great. Yep. Partner. I see front door. Wonderful. I know we had a question earlier. I just want to provide the response here about slides being provided post-call. Yes, the slides will be provided. So very good. Front door. Very nice. Thank you for participating here. There are a number of different responses from our audience today. So let's move through these one by one. Let's start with front door. So if you take a look at this, we often assume that the actual problem is awareness. If members knew they were due, they would go. But the evidence and most of our real world experience, myself included, suggests that the problem is often friction. The appointment may be difficult to get. There might be transportation, might be barriers here. It might be things like the nature of the test, not hearing back. Dr. Rob, I'd love to hear your perspective here as we're talking about that front door. How these are really, we can't assume that it's just an awareness issue.
Yeah, we touched on this on an early slide, but when you really break down, the reason people aren't getting tested, awareness is actually not, well, there certainly are some patients. I'd say awareness is probably the one area that the plans and us and others and the federal government have done a pretty good job about at least making people aware that there's some testing that should be happening. But there are those barriers. We mentioned them earlier. We'll kind of click on them again very quickly. Uh, the ability to get into a provider. Do they take my insurance? What's the wait time? What are the referral hurdles that might need to be in place? Having to physically go there? Is there transportation challenges? Distance to a facility? I mentioned before about, the challenges in rural healthcare. Also, having to get away from work to be able to do that, or childcare, home care issues, things along those lines. Sometimes it can be the nature of the test. Is this a test that has to be done in a doctor's office? Do you have to then go to the doctor's office, but be sent from there to, a third party to have the testing done for laboratory or imaging? Maybe it's some potential concerns around the invasiveness of the test. If you think about colon cancer screening specifically, if somebody does a screening test, like a FIT test, for example, which is non-invasive, but if that were to be abnormal, then that's going to lead to a colonoscopy, which, well, minimally is still an invasive test. Maybe there's some embarrassment associated with that. Um, and then I think another component that we haven't mentioned is sort of what happens uh, after the testing is done, which is how do you actually get that information, or does that information get back to the individual who is tested? And does it get back to them in a way that provides them education, resource, next steps about what to do with that information? So it's not just enough to say, yeah, you did the test, it's abnormal. Well, if that's where you end, then you've really not done much at all to help that individual. So you've got to get them to that next mile and beyond to really be successful. And I think, as we're going to talk about here, in some of the slides ahead, this really gets to the point of where one of the major shifts is happening in terms of how you close gaps. It's not enough to just say, well, we did the test, or we sent the test, or we referred the patient for the colon cancer screening, or that, we gave them the order for the lab slip. That does not close it. It doesn't close it anymore. It's about the care that needs to come based on that result. And it's not just that you provide the care, but that you actually document that the care has been provided and that you're shifting that patient's health journey, hopefully in the right direction.
That's right. Absolutely. And as we go on to the front door, and the really it needs more than one entrance. We know that members don't engage with healthcare in the same way. Some want the convenience of at-home collection. Others want virtual care. Some may need to have someone physically present. Others prefer a retail or a lab setting. And for many members, the primary care relationship remains really the most trusted pathway. So, care management also has an important role for members whose barrier isn't just convenience, it's complexity. So, I think the modality as a segmentation strategy is also important here. It's not so much which channel do you prefer, it's more which members does each channel reach and who are we still missing? So when you take a look at it, who are those members that are still left behind? So as we keep going here, Dr. Rob, what does a genuinely flexible preventive care strategy look like? And where should a plan start today, or where should a plan start if today's program is a one channel and perhaps a one annual push type of program?
Thanks, Pete. I think a lot of this comes from our learnings over the years of delivering these types of programs across a wide swath of clients. And so these are, in large part our own learnings about how to do this and how to try to be more successful perhaps than what has been done in the past. I would say from the start, I would encourage plans to design their programs in channels that are around the channels that have failed. In other words, they're non-responders. Let's not always just go after the low-hanging fruit of the patient that's done their screening routinely every year, religiously for the last decade. While those patients certainly should continue to do their screening, the ones we really have to be most concerned about are the ones that have fallen way behind on their screening. So let's look at the non-responders. The second component would be to be certain that as you build the strategy, that the strategy absolutely includes actionable results. And I mentioned this earlier when we were talking before, it's not enough clinically or from a gap closure credit perspective to just say, well, we we did the test. Um, there has to be defined next steps beyond that point. So, what are we going to do with people that have a normal result? In other words, there needs to be education for them too. Just because your result is normal today doesn't mean you're one and done, right? It means terrific, you've engaged in your testing, great news, your result was negative, but here's what the future should look like. Here's what future testing should look like from a calendar rollout, and to make sure that they're at least aware that testing in the future is going to be important and define what that looks like. And then for the group that does have the abnormal result, what are the definitive actions there for those people? And make sure that we're not just educating and informing, which we absolutely need to do, but then taking them to that next step on that journey. Because ultimately, what we've got to be able to prove, and this goes to how these measures have changed and are changing in the years ahead, we've got to prove that we're actually altering in a very positive way, in a favorable way, the outcome. And then the final component, and this is really for the plans to think about again as you build your strategy, is to make sure that you're able to document that completion. So, for example, outreach, just showing that we reached 50,000 members or what have you, that's an activity metric. That just shows that, yes, you're active in the space, but it does not complete the measure. Completion screenings mean that you've delivered results, and that outcome from that becomes the metric. And so, put another way, a result that never reaches a member or the primary care doctor overseeing that member has closed a data gap, but it hasn't closed the care gap. So, you really have to be sure that you're considering all of that to be successful.
Absolutely. Which brings us to timing, because everything, Dr. Rob, that you have described here takes time to actually work into the plan. So we know that early success is critical. It's extremely important to start that conversation earlier. A last quarter sprint can work for certain process measures, but clinical outcomes operates on a very different clock. If you identify a risk late in the year, there may simply not be enough time to intervene, to treat, to retest, or even to document that improvement. So, truly, when we talk about a comprehensive strategy, it should be a year round strategy that isn't necessarily about doing more outreach. It's about sequencing that same work earlier. So, if you want to enter Q4 managing expectations, not trying to manufacture outcomes for the majority of your population. So let's take a look at one concrete example here as we look at a 12-week program. Dr. Rob, can you walk us through what this actually looks like in a year for a member with at-risk blood sugar levels?
Absolutely. And you can extrapolate this sort of runway to a lot of different disease states. And we're going to talk for a moment about what that means. And, as you talk about blood sugar, pre-diabetes and diabetes screening, but, this actually can be applied to screening for kidney health and making sure that somebody isn't on the path to renal failure, for blood pressure control. So this isn't unique. What we're about to talk about, or what I'm about to talk about, is not unique only to diabetes screening and pre-diabetes. But in that setting, and you look at what we term glycemic status. Basically, what we're talking about is measuring somebody's blood sugar. The testing for that is something called an A1C. It's a blood test. It's widely available, quick turnaround from the lab, very reliable in terms of the result. Um, what an A1C is actually testing is not what that individual's blood sugar is that day, but rather what their blood sugar is over an extended period of time. So it's really giving you a much better idea of where does that person live day in and day out in terms of their blood sugar control. It's very easy to manipulate your blood sugar minute to minute, hour to hour. In other words, if first thing in the morning before you have a meal or have anything to eat and you check your blood sugar, that's going to look different than if you have a glass of orange juice and check that blood sugar 20 or 30 minutes later. So that's not really telling you what's going on with the individual. But if you go through the A1C blood test screening for prediabetes and you identify somebody that is either diabetic or in that pre-diabetic range, um, if we call that day zero, and we're now going to intervene to clinically improve that so that their blood sugar control is better, and we can do that, as I mentioned earlier, through a variety of methodologies. It may be diet, education and control and alterations. It may be adding in exercise, and it may be medication initiation as well. Um, some or all three of those in certain cases. But if you did all of that on day zero and you got it perfectly right by day one, in other words, let's imagine, which is unlikely, but let's imagine that the dose of the medication was correct, the patient was spot on with their nutrition changes, they committed to their exercise program on day one. Even if their blood sugar gets better, it's not going to be reflected in their lab panels for at least 90 days. And that's just because of the nature of the A1C test testing the blood sugar levels as it relates to their red bloods, or their blood sugar levels as it relates to their red blood cells. And that turnover takes 90 days in and of itself physiologically within our body. So even if you do everything right from the get-go, it's going to take 90 days before a repeat measurement will show that you're heading in the right direction. So even if you check that person who's doing everything perfect, but you recheck their blood test at 45 days, it's not going to look much better. You've got to have at least 90 days, which is why then, if you want to close the gap, it's a 12-week problem. And again, you can take that same scenario and apply it to some of these other disease states or that we screen for. But I think for the purposes of today, plans just need to be thinking about this is not going to be quick in terms of proving the clinical improvement, the clinical outcomes.
Yeah, absolutely agree, Dr. Rob. I see a questions come in. Let's kind of take a look at this one. What factors or member characteristics are associated with failed outreach in your experience? How can we improve outreach to difficult to reach members? I can,
Yeah, I mean, I'm happy to try to take a stab at that. And
perfect,
again,
Dr. Rob, thank you.
this is from our own learnings, but I think I would answer it as it needs to be multi-channel.
Yeah.
So what works for one individual may not work for the next. And by multi-channel, I mean lots of different ways to try to do outreach. Mail, text, phone call, interaction with an identified PCP that the individual may have. You may need to bring all of those things to bear to get one person properly connected and screened. So I
Yeah.
would my answer to that would be multi-channel. But I don't know, Bina, do you have different thoughts or other thoughts on that?
I couldn't agree with you more, Dr. Robin. I actually have a real life example. You may remember last year, a national health plan came to us. They were struggling with their breast cancer screening, and they were using another vendor to reach out to what they had as the high priority contract of theirs, hardest to reach. This other vendor could not reach it, and they decided, we'd love for you all to cut your teeth on it. And, we were excited, obviously, but we were thinking to ourselves, well, another vendor's already tried them. They weren't able to engage them. So we're really, for a pilot program, getting the roughest members to engage. We were able to showcase a much higher engagement, doing exactly what you just went through, Dr. Rob. We did that multi-channel engagement with this particular non-compliant membership group, and we're able to show an increase for this health plan's breast cancer screening rate. So that's a real life example of exactly what you've described, in which we did it for one specific measure, which was the breast cancer screening.
Yeah, and when I think about, and I know the use case that you're referencing, when I think about that particular program, I think one of the things that really set us apart and made it as successful as it was and continues to be successful is, and we talked a little bit about the idea of not just a test, but wrapping that to the next mile and beyond in terms of making sure that you're carrying that person through. In the case of the breast cancer screening, it wasn't about just getting a hold of the individual and say you're due for your breast cancer screening. Once we had actually connected with that patient, we actually, while we had them scheduled their mammogram for them with them on the phone. And so we made sure that they knew on Tuesday at 2 p.m., and here's the address, this is where you're going to go. And then on the back end of that, we made sure that we got a result back where that screening was supposed to be done. And if it wasn't done, we would then reach back out to the person and say, hey, last Tuesday you're supposed to have your mammogram. It wasn't done. Can we figure out what may have happened? How do we get it done? And then we were certain that we got the results back and then got that back into the members' hands so that they were aware of what those results meant and what they should do next.
Absolutely. Well, we know that earlier identification creates options, Dr. Rob. Could you walk us through what earlier identification actually buys you clinically? I mean, what can you do for a member in February that you simply could not do for that same member in November?
Well, I mean, I think clinically, it doesn't matter what the calendar says. You can always try to intervene. I think if you think about it from the perspective, however, for the purposes of the people on this call that are looking to make sure that they're closing gaps and reaping the financial impacts of that gap closure, as we mentioned, it takes a while to prove the outcome. So in the pre-diabetic, and I mentioned that a few minutes ago, we talked about the idea if you change the management to you identify it, you change the management, it's going to be at least 90 days before you can even prove that that person's getting better, is shifting away from diabetes, and actually moving their health in the right direction. Um, but I don't want to harp on that. I think we've kind of mentioned that. I would say, though, that what it means for our audience is shift your thinking. This can't happen December 1st to launch your program. You've got to leave yourself and your member plenty of runway to not only identify them by doing the testing, but then implement the necessary therapies to prove outcome.
Yeah, absolutely. And of course, none of this works if the plan may not be able to orchestrate all of those activities across a fragmented ecosystem. So when we talk about really choosing a partner and not a point solution, it's that each vendor was brought in because it solved a real problem. The challenge is what happens over time. You can end up with fragmented data, duplicated outreach, perhaps multiple operational processes, and ultimately a member receiving several disconnected experiences from the same health plan. So, as the STARS environment becomes more outcome focused, that fragmentation becomes increasingly expensive, not just financially, but operationally and clinically. So the question becomes, do you have a collection of solutions, or do you have an ecosystem that can actually coordinate the member journey? So, what does consolidation really look like here? What consolidation buys is one, a single view of the member. So you have one view of the member. Second, you can sequence those interventions. So if you know that a member has multiple open gaps, you can determine what should happen first rather than sending three unrelated interventions at the same time. And third, you gain agility. So consolidation isn't simply about reducing maybe the number of contracts. It's about creating visibility required to make smarter decisions about the member. So, how would you evaluate whether a partner can deliver that? So, as we take a look at this, there's 6 questions to ask any partner. And I'd encourage everyone to take a screenshot of this slide. Again, we will be providing these afterwards, but these 6 questions can change the quality of any conversation, whether it be with the procurement department or quality departments or whoever. You shouldn't just ask what the solution does. Ask which member measures does it actually impact. Ask what happens when a result is abnormal. Ask how the result gets back into the clinical record. Ask who the modality reaches and who it misses. And critically, ask about the implementation lift and what happens when the regulatory environment changes. So these are questions that force a partner to demonstrate that end-to-end accountability rather than just a compelling point solution. So let me turn this back to the audience. Which of these 6 questions do you think vendors get asked least often today? If you had to take a look at all 6, which of these do you think vendors get asked least? And as some of those are coming in, they might be coming in directly, Dr. Rob, to you or myself. We can kind of take a look at this. I know I've certainly heard from others that it is really about the implementation lift and what happens when the regulatory environment changes. For some others, it might mean which measure actually has impact. So as we've talked to our clients, it may broadly kind of differ. We see some responses coming in. Number 6, number 4, 2, 3, 5, and 6. Yep, it may be more than one. Number 5, number 2. Great responses here.
Sounds like all the above, Bina.
All the above. I think all 6 of them, depending on the day. That's exactly correct. Well, let's take a look at this, putting it into the year. So, what does a year round model actually look like? It could be where in Q1, you're identifying, you're refreshing the gaps, you're stratifying the members, you're starting early in Q1. In Q2, it could be intervening, delivering the intervention, routing abnormal test results to close that clinical loop. It could be in Q3 where you're remeasuring. So confirm whether that intervention worked, escalate members who still need attention. It could be the last quarter, you're managing expectations. Instead of trying to reach everyone, you're really focusing in on the members who truly need additional intervention. And you're making sure that your data is not just complete, it's correct. So correct and complete. The key is that we're not asking teams to do 4 times the work. We're resequencing the work so the calendar works for clinical care instead of against it. So let's take a look here as we transition into one example of how the shift is happening right now for colorectal cancer. What does this look like in real life, Dr. Rob? Can you talk about colorectal cancer screening versus follow-up after the positive result and how this may impact plans in the future?
Absolutely. And, this is HEDIS has kind of gone this direction. CMS is likely going to follow shortly on this as well. So I think everybody really needs to get their head around this, which is that if you think historically, The health plans were evaluated strictly on whether the members had completed uh, a colorectal screening of some type, and that could include a colonoscopy down to a simple stool-based test like a FIT screening. Um, you send the kit out, the kit comes back, that's it. Gap closed, check the box, move on. But one of the big changes is now starting in 2027, that rule changes. NCQA is introducing a brand new measure deemed the follow-up after positive colorectal cancer non-invasive screening test, or COF-E. Simply getting a member to complete a FIT test will no longer be the finish line. The bottom line is that if that non-invasive test is done, but it comes back abnormal, then the job isn't done until that member has now completed the next step, which would be the colonoscopy. So the further diagnostic. So what's the takeaway? A positive kit is no longer a successful metric. It is simply the start of a required clinical handoff. And you've got to make sure that as you build this program, that you have the capability to do that handoff and see it through to its completion.
Yeah, absolutely. So really what I'm hearing from you, Dr. Rob, is building to run the whole loop, not just one step of it. And I think that's where our capabilities come together. We can support the screening itself through at-home collection with multiple delivery models designed around all different populations. We have a CAP accredited laboratory, significant sample processing capacity. We support clinical follow-up when results are abnormal, including clinician outreach to help explain the result in the next step. And more importantly, we don't view the lab result, just as you had just outlined here, as just the finish line. So it is a multi-channel engagement. It's reporting so the plan can see what's actually happening. So those are all the kind of pieces that we are saying it's not just one step, it's the entire journey. So as we bring this conversation to a close, I want to leave you with 5 practical actions. So as you take a look at these 5 things that can take you into Q1, there's really a baseline. So you first rebaseline your measure inventory against the calendar year 2027 set. Then you identify the outcome measures carrying the greatest weight and work backwards from that clinical timeline. Next, you might build your depression screening and follow-up workflow now rather than waiting for the rating impact. And I can certainly attest to this, where we've had a number of our clients approach us and say, we really want to start to take a look at this. We want to see if we can do something in Q4 so we're ready to go when Q1, Q2 starts. Here, the last one, fourth, look at members by the number of open gaps, not simply the gap type, so you can prioritize the people with the greatest opportunity. And finally, take these 6 partner questions back to your existing vendor ecosystem before adding yet another point solution. So we want to make it easy for you, and we want to certainly keep the conversation going after today. So as we take a look here, we know that certainly almost 55 minutes isn't enough time to unpack all of this, particularly when you're thinking about how these changes apply to your own population. So we are going to make this recording here available to everyone that's registered. I encourage you to use that material with your stars, your quality teams, your clinical teams, perhaps your population health teams, because it really shouldn't be a conversation that lives within one department. The shift towards outcomes touches the entire operating model. So we will continue to bring these conversations to market at Fuse Health, particularly as the STARS environment continues to evolve. And if today's questions and discussion has really brought up other questions for you, or if you're thinking, we have pieces of this already, but I'm not sure how it all fits together, that's the exact kind of conversation that our team wants to have, is to say, we're bringing some best practices to bear. Here's how some other health plans are looking at it, or some other areas are doing it. So again, we hope you follow Fuse Health on LinkedIn. You stay connected on upcoming webinars, insights, and practical perspectives on improving preventive care and population health. So let's take a look at if there's any other questions that have come into the chat here. Has LGC ever thought about investing into state-based health records, getting data into health records? Dr. Rob, I may turn it over to you in terms of, have we looked into this? Is this part of the conversation, or thoughts around this?
Yeah, it definitely is something that we consider. I think the challenges become that there's no uniformity there. So, from a compliance perspective and keeping a lot of that information secure and safe, it poses a lot of challenges on those fronts. So certainly something that we have considered and continue to consider. It's a matter of how do you do that safely and efficiently and not in a burdensome way to the enterprise.
Absolutely. Very good. Thank you for that. Let's see if there's some others that have come in here. Dr. Rob, I have one here. We already run at-home testing and our return rates are low. Why would another vendor be any different?
I suppose it depends on what kind of testing we're talking about, and what the methodology of outreach was. So, if it's, for example, we just bombarded people with a letter and said, if you want to do testing, call this number. uh, I would expect that program's going to fail probably. So I guess I'd want more details about the kind of program and how it was run in terms of what the engagement strategy was. The other thing I would keep in mind is that when we talk about closing gaps, and we sort of reference this, but we didn't really call it out directly, there are different methodologies to close gaps. And so this talks about not just being a point solution. So if all you do is colon cancer screening and that's going to be stool based, that's a one-trick pony. But if we look across a lot of the gaps, whether that be, from depression screening, that's going to require interaction with the individual, whether that's, in the case of colon cancer screening, that's stool-based, whether that's diabetes or kidney health, that's going to be, blood and potentially urine-based testing, so laboratory. And then if you get into things like um, uh, uh, cervical cancer, HPV. Now you've got, cervical swabs that can be self-collected, but then you also get into all the imaging modalities that can be used to close gaps. So lung cancer screening using CT, mammogram screening to screen for breast cancer. So these are imaging modalities. And so I think you want to try to have not that you can ever have all of them in your war chest, but you'd like to have as many different modalities in your war chest so that you can get the most amount of coverage, the most amount of bang for your buck. And I think it's important to keep in mind from a vendor perspective, the more things that you've got in your war chest, when you do actually successfully engage with that individual, for example, let's say somebody's due for their colon cancer screening, they may well also be due for their mammogram and their cervical cancer. If you've got all that in your war chest, you can actually close multiple gaps with one intervention or with one engagement with that individual. So just something to think about.
Absolutely. Dr. Rob, I think we have time for one other question here. It's come through. Will the reporting fold into the current Let's Get Checked dashboard?
I believe the answer is yes, but I am not the tech person, so I would leave that to our implementation team. But I would imagine that would be an important step to being able to close that gap in a way that allows it proper reporting.
Absolutely. Very good. Well, again, thank you all that have remained with us through the duration of this presentation. Thank you for spending the time with us. More importantly, for the work you're doing every day, really to make preventive care actually happen for your members. Dr. Rob, thank you for your time and expertise today. If there's additional questions, please reach out to us, and otherwise have a great rest of your day.